Okay, so we talked yesterday a lot about histograms, and we were just ending at the point of histogram error. So we know a lot of different things can cause a histogram error, and mainly it's the cause of the raw data histogram not aligning well with the lookup table, and from that issue we can get a histogram error. So this is one example of a histogram error here. In this particular instance, when we're using CR imaging, that we have to make sure that if we're going to collimate, we're collimating equally around all sides. So get my pointer here, sorry. So here you see this is collimated equally around all sides. The system can recognize that as unexposed areas instead of volume of interest recognition accurately. And so this image will turn out nicely. However, this particular image probably was at the same technique, but you can see that the tech collimated on the inferior portion of the IR, not on the superior portion. Therefore, it wasn't equal collimation around all four sides. And so what's happening is the histogram is having difficulty setting that field of view, region of interest, volume of interest, representation lines to exclude non-image data. So the idea of using a histogram is really to maintain consistent image brightness despite very slight changes in technique. So in this example here shows that this has high noise, probably quantum model, because we have low reception exposure. This X-ray would have adequate or even optimal technique with no scatter or minimal scatter, no quantum model, falling in the optimum range. And then this one would have still be very good, but it's going to actually be overexposed. And so what the histogram is going to do is try to align all three of these exposures under one lookup table. And by doing that, it remains it provides consistency to images for the physician to evaluate. Okay, so we talked about how our exposure index or our exposure indicator EI value is going to be useful in describing how well our system has or how well our technique has worked. So where we get the exposure index from is when we have that histogram and we set our S max here, our S min here, and then in the middle we set our S average. That S average is going to be read out as our exposure index. So if my exposure index target for my system was say 800, like ours is, and my exposure is greatly underexposed, my S av might land at 200. Therefore, it would tell me that my exposure index was 200, and it would guide me to needing two doublings of my mass to get to 800. So that's where it comes up with the exposure index from, and that's why it's so useful for us. Now, again, we've talked many times about the inconsistency between manufacturers. So in this case, we have a little table down here at the bottom that just shows how, Carestream, Kodak, they're going to refer to the exposure indicator as an exposure index. If we go to Fuji and Konica, they use an S value, S representing sensitivity, and AGFA is a log medium value. So any manufacturer is going to have a different exposure indicator, and so what you'll have to learn is how to identify what the target is, what the range is, and then how to adjust appropriately for your system. Okay, so the deviation index then is also a recommended universal standard for indicator. Now, rather than the exposure index telling us how much exposure we had, so it could guide us to get where we wanted, the deviation index is looking at basically our exposure index, and it's saying how far off are we from what our target was. So a deviation index of 0 indicates that there's no difference between the desired exposure index and the actual index. So in our system, in our lab, if I took a chest x-ray and my target is 800 and my exposure index is 800, my deviation index would be 0. Now, the farther you're going to get from 0, obviously, the more under or overexposed you are. So a DI above 0 would indicate overexposure. A DI below 0 would indicate an underexposure. Just department standards of how far over or under should be allowed should be made and posted. Okay, now with exposure index and deviation index, there can be some limitations. So because they're generally made off of the histogram, anything that could cause a histogram error could theoretically affect your EI and DI numbers. So if you over or under collimate, that would affect your histogram. If you over collimate, you're going to have a decrease in signal or intensity. If you under collimate, you're probably going to have excessive scatter. Both of those two issues would cause a change in your histogram, which would therefore affect your exposure index. Using extremely high KVPs or very low KVPs can affect your exposure index in that you will get either with the high KVP, you might get excessive scattering. With the low KVP, you might get minimal scattering, and either of those would affect your histogram. Centering the image to the IR, especially in our CR systems, can have a significant impact on the histogram errors, and setting those field of view lines. Inaccurate anatomic part selection causes the inaccurate selection of the wrong lookup table, and so that would lead to exposure index or a histogram error, leading to it then therefore an exposure index error. Inaccurate data extraction or computer rescaling would be an error within the system. It's not able to it's having a challenge in aligning that raw data with the lookup table, so you have an error in rescaling, and there again you can find an issue with the EI and DI. And we want to evaluate noise along with EI and DI values, because if I have a decent looking image, or excuse me, if I have a good EI but my image looks way too low contrast, then that would be a contrast noise that I'd have to adjust. So even if I was in range with my EI and DI, then I would still need to do a repeat exam. Okay, lookup tables, we talked quite a bit about this yesterday. These are the method that we're going to basically overlap our lookup table with our raw data to do that rescaling process to produce the best outcome image. So the lookup table itself is a method of altering the image, changing that image by use of computer algorithms that can adjust the pixel values to change the display. Okay, so we're going to go a little farther into our lookup tables. So with our lookup tables, if the original image is altered, that original pixel value would be different in the processed image than it was in the raw data. And the graph would no longer be a straight line if you're looking at a lookup table like this. So where they're saying this is a straight line on the lookup table graph, if we've altered it through the rescaling process, you'll no longer have that straight line. And therefore, the pixel intensities would be calculated to display on the image with a different color or shade of gray. So here's an example. Let's say that I had this very low contrast image in my raw data. I superimposed it over my lookup table. It adjusted that image to the lookup table, and that lookup table sent the same image out, but it adjusted it to a more contrasty image. Here's another example where by adjusting the selection of lookup tables, you can invert it, meaning make all the blacks white and all the whites black. You can cause it to become high contrast, as we saw up here in this particular example, or we could cause it to become lower contrast if we were to run this high contrast image through a lookup table and rescale it, we would get this low contrast image. So that particular aspect can go either way. Okay, so here you just see a couple more examples of the process of these lookup tables, and so hopefully you're feeling pretty comfortable with those. Okay, here's just a couple more examples of what the lookup table of this chest may look like. We see a little bit of whites, a whole lot of grays, and a little bit of darks. Over here we have very few whites. We get these, or excuse me, up until this point, we get these spikes at brights, and then we get a spike at our blacks, but very few grays in the middle. Now, like any other imaging, digital imaging is subject to artifacts, so there can be a number of different causes. Some of those are going to be under our control. A lot of them will be out of our hands. They'll be so deep into the system that it's going to take, somebody to working on the internal components of a cassette or the internal components of the workstation and image processor to get these resolved. But we need to know which ones we can control, which ones we can't, and be able to identify which one's which. So there can be numerous causes. Usually an artifact is seen as something extra bright or radio opaque or extra black or dense. So they can be classified under 4 different categories. So you can have something that occurred prior to the ADC. So that would mean something in the system, maybe in the thin film transistor, maybe there's an issue with one of the capture, coupling, or collection elements. Anything like that would be classified as a pre-ADC artifact. Now, we could not do anything about that except call for help. Then we have something during the ADC. So this would be when our ADC is processing those electrical signals and creating digital values to represent the electrical signals. If something occurs here, it can affect our grayscale. Again, this is not something we're going to be able to address. Then we have our after the ADC. So after the ADC would be the process where we have the digital data. So somewhere between our digital data and where it actually gets displayed, we're going to have an error. And then finally on the digital display, so the computer monitor itself. So some of the examples of this, if we want to look into particulars, would be for this prior to the ADC, it could be something like on a CR cassette, you could have a scratch on the cesium iodide where there was no longer any capture element there to collect photons. Therefore, you're going to get an artifact on your image. If it's an indirect or a direct digital, then you could have an error in calibration of the detective element within the pixel. You could have maybe an issue in your TFT with the transistors not functioning or not timing the release of data from the capacitors. Those could cause some issues. So that would definitely be an issue. Both of those would definitely be examples of issues prior to the ADC. Now, when we look at actually our image display, I'll tell you that radiology education has changed considerably in the last 20 years in this area of study. So originally we used to have to know everything about film, how it was processed, all the chemical reactions within those processing systems. But now they have actually removed that information from the boards, and now we're concentrating more on just the digital display. So when we refer to soft copy viewing, that means that our display is digital. If you ever hear somebody say a hard copy, that would mean that they actually have a physical printout or film that they're reviewing. So our image displays, our digital image displays are always going to be referred to as soft copy. Now that we are so dependent on these soft copy images, we can't just grab any old monitor or TV and assume that we're going to get an accurate view of an image. So now they've put a lot of time and energy and study into image displays. And we've had to start doing a lot more quality assurance on these displays to ensure that what we're really taking is actually being seen. So some of the things that we have to look at regarding an image display is the display's luminance, its resolution, the ambient lighting in the room, and even some more. So the primary display monitors are the ones used by the diagnostic interpretation. And so these primary monitors are going to be the really, really good monitors in the radiologist's office. Our workstation will be our secondary monitors, which don't need to be as high quality. Now, I'm not going to go too deep into our cathode ray tubes at this time because we're actually going to study them some in our fluoroscopy unit. But our cathode ray tube is, if you can remember maybe your grandma, or you guys, maybe your great grandma, probably had a TV that was about 4 feet wide and about 3 feet thick, and it maybe even sat inside of a big wood cabinet. Those were the old cathode ray tubes, and what they did was they functioned off of analog signal. And so there would be an analog signal sent to what we call an electron gun, and that electron gun would take that signal and it would shoot it out as electrons in a raster pattern, like where we go left to right and then top to bottom. In this raster pattern across, so this is a side view of the cathode ray tube, it would send out these electrons. This is the front tube of the tube, or the front aspect of the cathode ray tube, or the front of the TV. Those electrons would activate the front of the TV, and it would produce light on a graphite screen, and that's how you would actually visualize an image. So that's really common until really the late 90s that you would have a cathode ray tube. So since then, we've pretty much transitioned to liquid crystal displays or to plasma displays. So while we still have to cover our cathode ray tubes, again, I'm going to talk to them more extensively in our fluoro unit. So for today, we're mostly going to be concentrating on our liquid crystal displays or our plasma monitors. So one of the things that's a very basic concept you have to understand about most of these displays is that they're backlit. So if you're looking at your computer right now, you'll see this really white screen. Okay, so two things could be happening here. Either I have a white background with black covering it up, or I have a black background with white covering it up. So for most of our liquid crystal or our plasma displays, what's happening is that we have a white background or a white display with the black data, in this case, covering over it. Okay, so when we have liquid crystal, it's exactly what it says it is. It's a crystal that is kind of like, we talked about how amorphous silicon can be changed to different forms of solidity. Liquid crystals are the same. They're crystals in a liquid form. So they will create these liquid crystals over the top of something similar to a TFT and display the image on a glass faceplate. They can use that TFT to provide individualized pixel stimulation to create the data on the image. So here you have just a little visual of a cathode ray tube here on the left, which you see it has a much more significant depth versus either a plasma or a liquid crystal display here on the right. So when we look at the internal components of how these function, on the left kind of describes very much more accurately the cathode ray tube, where the signal is provided through electronic circuitry coming in here to the electron gun, and then that electron gun shoots out electrons proportional to the incoming signal, and those electrons are then focused via the focusing coil and the deflecting coil to hit the accurate area on the anterior screen. So there's the anterior screen is graphite in nature, but it has a posterior fluorescent screen. So when an electron hits that fluorescent screen, obviously it's going to glow, and so that's where you get the brightness coming through. So in this particular case, it's actually a black screen made to glow. Now, that's different from our liquid crystal display in that it is constantly backlit, and then it has a polarizing filter, an LCD layer, and then another polarizing filter. Now, that LCD layer is going to have pixels kind of like a TFT. And so the light is always shining through, but let's say I want to make this L on my screen to cover up the brightness, then that signal would go to the individual pixel in the LCD layer, and it would trigger that pixel to create a blackness over the fluorescent light, covering that light and creating this L. Now, Especially more so even for the radiologists, obviously. But the placement of the display monitors is going to be very well thought out. So it has to have an adequate amount of ambient light so that there's not any disruption of the ability to view the image. The monitor matrix size should be at least as large as the imaging receptor matrix size, because as we know, our systems are limited by the weakest length. So displays are going to be cheaper than image receptors, and so we certainly don't want to lose any of the detail from the imaging receptor to the display. So they should be equal or more capability than the image display. Monitors that have higher luminescence ratio are capable of displaying a greater grayscale. So the luminescence ratio is when we're illuminating something, that means that the light is coming directly from that object. So when I turn the flashlight on, the light coming from the flashlight is luminance. If I shine that flashlight against a wall, the light that is reflecting off the wall is called illuminance. So there's a really important differentiation between those two terms. Pixel depth here also affects contrast, because we know the greater the pixel depth, the more shades of gray available. So this is a secondary part of contrast after the analog to digital converter of the system. Monitors with higher luminance, again, can display that greater grayscale. Visualization of the image can be affected by spatial resolution, as well as the luminance and the contrast resolution. If the luminance is decreasing, then you may have a reduced ability to represent all the different shades of gray. So, like I mentioned before, our attention that we pay to these soft screen display, to imaging and viewing soft images on these displays has required a lot more performance criteria and more guidelines or requirements as to what these displays can do. So one of the ways that they have produced some different options for monitoring the display's performance. So there's a couple different groups that are actually in charge of developing these quality control devices. The first one historically that was used was the Society of Motion Picture and Television. Engineers created a SMPTE test pattern that was utilized to test displays, because that was sort of their realm of expertise. However, as imaging has become so much more of have such a greater stake in the ability of displays, this other group, the American Association of Physicists in Medicine, or the AAPM, started developing quality control testing as well. So the testing pattern that you see on the right, I believe, is an AAPM test pattern. Bushong's goes into this with a little bit greater depth, so we'll talk about this some more shortly. But the idea of these test patterns is that we need them to help us distinguish if there's any geometric distortion, what the level of luminance is in our system, what the resolution and contrast resolution the system's available of, if it's producing any noise, and then we evaluate basically the ambient light, looking for any types of veiling glare. Now, as we discussed before, that really once that image is displayed or showing on our display monitor, anything we do to that image after that particular point we can refer to as post-processing. So post-processing are software options available that allow us to manipulate how the image is displayed. So some of the most common post-processing options are going to be your electronic masking. This is where you can actually pull in a black mask around the areas that you do not want to be viewed by the radiologist. Now, the rule of thumb on this is that you never, ever, ever cover up anatomy that you imaged. And this person did a really great job in that they pulled that mask right down to where you can still see just a smidge of collimation here. You can see the field of view, and that's going to prove to the radiologist that nothing was cut off that was acquired. Another type of post-processing is window level. So this sets the midpoint at the range of brightness. So it kind of adjusts that SAV of the image. So if I wanted to make the whole image more bright, I would shift the window level to the left or to the right. Okay. Now with window width, that changes the range of shades of gray. So this is going to expand your dynamic range. So a wide window lowers contrast, meaning allows more shades of gray in, whereas a narrow window is going to allow fewer shades of gray in. So our wide window would be equal to a longer dynamic range, whereas our narrower window would be equal to a shorter dynamic range. So in that case, where the dynamic range is built into the system in the ADC, this window level and window width allows us to manipulate the number of shades of gray we want to use within that particular image. Now, anytime we add masking, windowing, or leveling, save that change and send it through to our radiologist. It resets, it moves us from the raw data to the new settings, and it will really limit the physician's ability to control or manipulate some of those changes. So here you can see the exact same chest x-ray. This one has a lot more shades of gray. In this case, they have adjusted the window width. If they were just to maybe take this particular raw data image and just make it much brighter, then that would have adjusted the level. Okay, so here's just an example, window level and window width. If we look here, fat, water, and muscle are all going to attenuate in this region, where air and bone are going to attenuate in these particular regions. If I have a very narrow window, I'm only using a certain few shades of gray. So they're going to distribute those areas across the available shades of gray. If I'm using a wider window, then I am going to distribute those shades of gray throughout a larger range, or distribute more shades of gray. Now, if this is let's say this is just my SAV, my center point of my image, and if I want to level, if I shift my SAV up, I'm leveling, that's going to make my whole image shift to be darker. If I want to shift it down, it's going to make that whole image appear brighter. If I adjust my window, then I am going to increase the number of shades of gray demonstrated within my image. Other post-processing techniques that you're probably going to use less commonly would be subtraction. This is where we're going to get into this more when we talk about like cardiac imaging or invasive, like an interventional procedure. But basically the idea is that it's the removal of superimposed structures so the anatomic area can become more visible. So what they will do is they will actually take an image, save that image, and then they will tell that image that it's a mask. Then they will take another image with contrast, and they will ask that mask, all the image that was on the mask, they'll ask that to be removed, so only the area that they injected contrast would now be visualized. So let's kind of run through this. So first of all, we take an image, let's say, of the heart. Okay, and then in subtraction, they're going to inject that contrast into the image of the heart, and they're going to tell it to subtract, and it will subtract the mask, or the first heart, out of the second image, so you would end up with just an image of the contrast. So on a very basic level, that's what your subtraction is. Contrast enhancement can alter the pixel values to increase enhancement. So it would just be a post-processing where the computer would recognize certain pixel values, and then it would increase the contrast by changing certain particular values. That kind of works like edge enhancement, which can be called high pass filtering, where it's able to recognize edges and then improve visibility of those edges by making subtle contrast or density changes. Inversion I have an image coming up here shortly, but inversion reverses the grayscale. So if you had, bone appearing bright and you, selected inversion, it would basically flip the histogram, and everything that was black would become white, and everything that was bright or white would become black. Smoothing is usually built into the system. It is a complex computer process that is intended to suppress noise, but because it suppresses noise, it often degrades spatial resolution. So smoothing would kind of use something called extrapolation or interpolation to, if there was missing data, say that I had couple pixels, let's say 3 pixels, and 2 of those pixels got signal, but the one in the middle didn't because my mask was set too low. That one in the middle would be bright and the 2 around it would be black. Well, if I turned on smoothing, my system would see this and recognize that it probably wasn't that there shouldn't have been any intensity there. It was that I used too little mass and it didn't get the intensity. So what it will do is it'll go ahead and average the surrounding pixels and assign it a pixel density value. So in that way, it kind of fills in the gaps, but with doing that, you lose some of the accuracy or the spatial resolution. Equalization takes underexposed areas and makes them darker, and it takes overexposed areas and makes them brighter, lowering contrast. And again, it's using algorithm recognition to identify areas that are light or dark and try to equalize that. Region of interest, that's where you'll often see your display demonstrate this, where your image comes up and you can see your collimated lines, and all of a sudden out of the blue it automatically masks all those collimated lines. And then stitching is something that we use when we want to image a very long area, but we don't have the image receptor size to do it. So an example would be for a scoliosis study. So a scoliosis study is going to have to go from above the C spine through the T spine and then through the L and S spine all the way to the coccyx. Now, most people are not going to fit on a 14 by 17 to get that image. So what they will do is they will take multiple images or they'll take images at multiple layers, and then the system will stitch those images together to make one cohesive image. So here's just an example of subtraction. So sorry, this is not the best example. This would actually be inversion here. This would be smoothing here. This would be edge enhancement over here. So you can see how that can affect. I'm not sure why I have this labeled subtraction. I'm sorry. Okay, here's an example of smoothing. As you can see, this has quite a bit of quantum model on this image. So what it did was in post-processing, we asked that image to be smooth. And so what it did is it would average pixels around probably an unexposed pixel because of lack of mass, and it would fill in those gaps with its best guess. So you can see you lose a lot of that sharpness, but it's trying to take this probably non-diagnostic image and convert it to more of a diagnostic image. Over here, you can see we know that T-spines are going to be really difficult to penetrate at the shoulders, easier to penetrate in the middle, and more difficult at the lumbar. And so we would have a very bright image at top and then a darker image down below. So this tech has applied equalization to try and to make that image a little bit more consistent. Okay, so this brings us to the next topic, which is our digital communication networks. Now, this is not exciting, I'll tell you, to me anyway. For some of you it may be, but it is essential. And what will often happen is that you'll be working with these systems and not really understand or even recognize, actually what you're working in. They're so entwined in what we do with all of our imaging that sometimes it's hard to recognize where one system starts and the other one stops. So the system that you hear about most frequently would be PACS. So PACS is Picture Archival and Communication System. So every time that you're in an imaging site and you save an image and send it to the radiologist, what it's doing is it's going to a PACS system, which is a storage system. These systems are fantastic because anybody that is a member or given access to a PACS system can then go in, retrieve that image, look at it, close it up, and it's still going to exist in the system. So multiple people can be evaluating an image at the same time, which may not seem that significant, but as before, if you took an X-ray image on film and somebody went and say checked that image out and took it to surgery and never returned it, that image was gone forever. Now you can have a surgeon in the operating room looking at it while the physician that's going to be caring for the patient in post-op is looking at it as well. So it just offers a lot of benefits. The other benefit it offers for you guys is previously with film, if you were going to image a patient, you'd have to go to the film room, get all their previous images, and then take them and give them the similar images from previous exams with your new image to the radiologist to read. And now with PACS, the radiologist can just search that patient. You send the new images across. They're automatically going to be able to pull up all the old images, sometimes from even different facilities. So pretty awesome. PACS system requires a ton of different tons of storage, computer storage, but is really life-changing in the medical field. Now, the next one, PACS and DICOM are often confused. So what DICOM is Digital Imaging and Communications in Medicine. And this was developed back in the 90s when they realized that, hey, this digital imaging thing is taking off. We need to do something. So they developed a very specific set of rules for all digital imaging so that when you take an image at a particular institution, and you send that image over to another institution, that institution is able to handle the data. So some of the things that DICOM regulates are, dynamic ranges of images. So each PACS system would have to meet all the DICOM requirements. So DICOM would be the rules, PACS is the actual system. And so DICOM tells PACS what kind of dynamic range it needs, what kind of what kind of resolution it would have to be capable of. So they work very closely together, but DICOM's the rules, PACS is the system. Then we have our hospital information system, which when you go to a hospital and you check in and they give you your medical records number, which is unique to you, but will appear on all imaging, lab, every kind of study you get from there on out. That's going to be putting your information into the hospital information system, or the HIS. The HIS also usually houses all of your financial, insurance, that type of information. Then we leave, after checked into the hospital, then you're going to go to the radiology department. You're going to check in there. Now, they're going to enter you into the RIS, or the radiology information system there. So the RIS system is then going to be where they enter your actual procedure that you're having done. So here they're going to put you in for your chest x-ray and maybe a knee. And for each time they enter one of those orders, it's going to be under your MR number from your HIS system, but each order is going to have its own unique accession number for each individual exam. So that's going to be housed in the RIS system. The other thing in the RIS system is often that radiology reports will be attached to the patient's information in that RIS system. It's also the RIS system that we're working from. Once that patient is checked into the RIS system, if you go to your imaging equipment, most of the time there will be a work list, and your patient will pop up there on the work list so you can select them and then apply your images to that patient. Now, another system, a computer system that's used, is called Health Level 7 Standard, and this is a communication standard for medical information. And I'm sorry, I said that was a computer system, but again, it's a set of rules. So we have DICOM to really set the rules for all of the actual images, but the HL7 is basically the set of rules for how HIS and RIS can work. All of these systems are linked in very complex networks and allow access to information in a convenient location and very little time with a lot more challenges. However, if you have, technology failure, our reliance on these systems can complicate matters significantly. Okay, in summary, I'll let you read through all those bullet points, and then I am going to pull up your next set of slides and record that separately. Thanks for coming.